everyone, my name is Minjung Cho. I'm one of the social media section editors of the Archives of Plastic Surgery. I'm excited to introduce APS Hot Off the Press. 2 times a month, we'll be hosting Hot Off the Press with one of the recently published APS authors and 2 panelists. You have a special opportunity to hear directly from the authors and join an insightful discussion between panelists. You can also leave your thoughts as a comment for further discussion.
Hello, everyone. Welcome to the Heart of the Press. I'm Kareh Kim, a social media section editor of the Archives of Plastic Surgery. Today's article is the use of arteriovenous bundle interposition graft in microsurgical reconstruction, a systematic review of the literature. Today, we have Dr. Kashyap, who is the assistant professor of the University of Miami, and the other author, Dr. Aurora Kareh from the St. Louis University School of Medicine, also with us. And Dr. Rocío Perez from the National Police Hospital of Peru, and Dr. Minjung Cho from the Ohio State University join as a panelist. Let's start with the introductory presentation. So Dr. Aurora, when you're ready, you can start.
Okay. So I'm presenting our article titled The Use of Arteriovenous Bundle and Interposition Grafts in Microsurgical Reconstruction, a Systematic Review of the Literature. This is a group effort. Myself, Dr. Tadisina, our great student Magnus Chun, and 2 of my attendings, Dr. Sumesh, Kaswan, and Dr. Kyle Shu, who, like you said, is with us today. So vein grafts have many available donor sites. They're easy to harvest and work well for smaller gaps, and they're very widely used when you need length discrepancies between a defect and recipient vessels to be bolstered or reached. And so the goal of this paper was to explore other options, specifically the AV bundle interposition graft. So 3 main ways that you can derive additional length when you have a length discrepancy between your flap and your recipient vessels. Like I said, are vein grafts, the most commonly kind of talked about, AV loops, and AV bundle interposition grafts. AV loops can span much longer gaps and can be staged, but they have limited donor sites, and there's a high rate of vessel size mismatch because of the donor sites available for AV loops compared to free flaps. And because of the required stripping of the loop, there's less intrinsic perfusion of the actual AV loop itself. And so AV bundle grafts are a great option because they're harvested as one soft tissue graft or pedicle that contains an artery and a vein with preserved interconnections between those 2 vessels. They're anatomically closer in size to most flat pedicles. They have decreased donor site morbidity than AV loops due to the length that you have to take. And they can achieve a more even pressure equilibrium between the artery and the vein. So like I said, the purpose of our study was to explore the indications, techniques, and outcomes of AV bundle interposition grafts through a systematic review of the literature. So we performed a literature review searching for the terms free flap reconstruction and interposition grafts, or arteriovenous interposition grafts. We initially found 186 articles, and then after eliminating duplicates and reviewing the articles for relevance to our study, we included 11 articles in our study. Amongst these 11 articles, 44 patients underwent reconstruction with an AV bundle interposition graft in those 11 studies. The average age was 48.4 years, 31 were male and 13 female. The most common indication for reconstruction was malignancy, followed by trauma as the second most common. All 44 AV grafts in the study were taken from the descending branch of the lateral circumflex femoral artery, which is the ALT pedicle, of course. And then there were a variety of different flaps that were used in addition to the AV graft for reconstruction. There were 5 complications across 44 patients. Only one, the venous thrombosis, was really truly a vascular complication that was intrinsically a vascular problem that could be attributed to the AV graft. There were 3 different techniques of AV bundle graft that were described across the literature. The most common that you can see here is the recipient lengthening technique, where the AV graft is taken and anastomosed to the recipient vessels prior to formally elevating the flap. And then the flap is subsequently anastomosed to the AV graft. This was used most commonly, so in 73% of all the studies. And this technique leads to shorter free flap ischemia time. The flap can remain in situ while the AV graft is being anastomosed to the recipient vessels. And it allows arterial supply through the flap to be verified easily prior to the flap anastomosis, because you can see the patency of the AV graft prior to formally transferring the flap. The venous supply, however, cannot be assessed with this technique, so that is one downside. The next most common technique was flap lengthening technique, where the flap was anastomosed to the AV graft with the AV graft in situ. And then the proximal aspect of the AV graft was anastomosed to the recipient vessels at the second stage. So this is essentially a double ischemia transfer that allows for both the arterial and venous supplies to be assessed through the graft prior to performing that second anastomosis. And this technique allows for mid-procedure reperfusion of the flap, which may be helpful in cases like trunk flaps where you may require a mid-case repositioning so that you're not accumulating all that ischemia time throughout repositioning. The final reported technique was revascularization of a lower extremity with the AV graft, and then concomitant soft tissue coverage with an ALT flap that was associated with that AV graft. So there are numerous cited advantages to the AV bundle graft. I mentioned some of them earlier. There's usually a reasonable size match to the flap pedicle, especially compared, like I said before, to AV loops that are usually much larger than the vessels that we're using for free flap anastomosis. And the AV loops can really dilate significantly and potentiate flow disturbances with the vessel because of the size mismatch, so that is less likely to happen with AV bundle grafts. There's also physiologic arteriovenous connections and vasa vasorum within that AV bundle that can compensate for pressure mismatches, prevent low flow venous states, and contribute to perfusion of the vessels themselves since they are a graft. Disadvantages of the AV bundle graft include shorter length compared to AV loops. So for very, very, very long discrepancies between flap and recipient vessels, this may not be the best option. And then, of course, you cannot use the flap that is associated with that pedicle. Should you take the pedicle and then require the flap at a later date, it's no longer an option to you. So the AV bundle interposition graft is a viable option for flap or recipient vessel lengthening in cases where additional pedicle length is required. And although indications do differ between these three major grafts, further studies comparing vein grafts, AV loops, and AV bundle interposition grafts are needed. Thank you.
Thank you for your presentation. Let's move on to the discussion part. Dr. Xu, do you want to add anything to the presentation?
No, Dr. Kareh did an excellent job summarizing this article. I'm really excited about this article because it really is going to change my practice. I've done a lot of AV loops and vein grafts for free flap reconstruction when there's a large zone of injury, but I've never done an AV graft, but after really reviewing the literature and reading this paper, I'm going to start using it. For example, I have a case this Thursday where it's a large zone of injury for a burned hand, and I'm going to be doing a latissimus flap. And to get out of the zone of injury, I was planning on doing a vein graft, but after really looking at this paper and reviewing literature, I think an AV graft is a much better option.
Which donor site did you use?
I would use I think the lateral circumflex femoral artery is a great donor site. It's easy to harvest. We're all familiar with the anatomy. It provides up to 20 centimeters of length. In addition, 60% of the time, it looks like from one of the articles by Zen that's in the references showed that 60% of the time it provides two veins. And as you know, many of the flaps that we do have two veins. So it'd be nice to be able to drain both veins, which is a problem with AV loops because it only provides one limb for the artery and one limb for the vein. And this provides both.
I see. So I also see the arterial venous bundle graft, interposition graft. It was the breast reconstruction using the lumbar artery perforated flap. You know, the pedicle for the flap is short. So actually they used the superficial inferior epigastric system. I think the lengthwise is much shorter than the descending branch of the lateral circumflex femoral, but I think it's also a good option too. Minjung, do you have any question?
Yeah, so I want to congratulate Dr. Kareh and Dr. Shu for a great paper. And I have a question. So there's a paper that I think it should have been included as a part of the systemic review, but it wasn't. So I was wondering how the process was. So this is piggybacking on Dr. Kim's paper. So there is a paper, it went over using a deep inferior epigastric perforator, like their pedicle for interposition vein graft and then arterial graft, just for the purpose of the lumbar artery perforated flap and also salvage reconstruction as well. And then also piggyback on the SIEA flaps as well. So I was wondering if it was just not part of the search or it was just considered just it wasn't included at the beginning.
There wasn't any exclusion of it. I think in hindsight, it may have just not been captured in the specific verbiage that we used, but most certainly kind of same advantages that are now very well published, I think, and well popularized by the UT Southwestern group mainly, that using the DIEA or the DIE A and B as an AV bundled graft for lap flaps is becoming more and more popular. So I agree, in hindsight would have potentially altered the search terms, but they weren't excluded specifically. But I think the advantages and disadvantages still apply in that case.
Yeah, because the good thing about that flap is that pedicle is it's used for a patient who had a tummy tuck. So you're not sacrificing a flap versus if you use the descending branch of LCFA, you potentially sacrifice the ALT flap for another cause. And then that was the only purpose that they used it for it. And then in that way, you're not really causing another donor site morbidity. It's actually easy to harvest as well, just like the ALT flap. You know where it is, and then you make a small incision over it, and they go down to the fascia, and just flip over the rectus, and you'll see it right underneath the pedicle. And then, depending on how long you need it, you could harvest it in a wide wrench. So you harvest the medial part of the pedicle. So if you need an extra length, then you could harvest it that way. But it's also good for any time you need it for salvage reconstruction. We use that for that purpose as well. Where your pedicle is short and also your stump is short, then you harvest that pedicle as like a cable graft between that.
Thank you, Minjung. Rochu, do you have any experience?
Yes, I was actually doing a question. First, I want to congratulate both of us for this amazing article. And the second, during my fellowship, we did 2 flaps with vein graft. We took this venous to do this vein graft for 2 flaps that we have a short length fibula flap, and ALT, I think, for was a defect for electric amputation that we did for this patient, and both failure. So I didn't like the vein graft. And actually, I found this article that Dr. Minjung mentioned. That's so funny. And I mentioned Dr. Akushida, and he said, the next time we have a short length, we're going to totally do this AV graft with this. But we never had like a short length. We didn't need a vein graft. The other case that we have with vein graft was revascularization for a hand. Was perfect. I mean, they didn't fail. It was amazing, but we didn't have like good luck maybe with these other 2 cases. But I will totally use in a AV graft next time, because I kind of don't trust in vein graft anymore. So I wanted to ask you, Aurora, in your experience, you're a fellow or a resident? I'm sorry, Aurora.
I'm a resident currently.
Perfect, because you already work with a lot of micro or plastic surgeon in your hospital, so you see different techniques. So in your experience, what is like, did you see this AV graft, AV loops, vein graft? In your experience, how many cases like work? You can say, I trust more in AV graft, I trust more in vein graft, because I saw more cases work with this.
I think that's a very fair question. I have more experience in vein grafts just because they're more common because of the type of defects that we need them for, primarily in hand. Did get some experience in AV loops with some crazy cases with Dr. Shu. But I think the indications are ultimately just different. And I think part of why vein grafts fail, there's an association in the literature between vein grafts and flap failure, vein grafts and flap complications. And I think it is more nuanced than that. I think it goes down more to when you plan an AV bundle graft, it's planned. And so you're going to take it. When you're doing a lap flap, you're not like, oh my gosh, it's so short. Like it's a planned thing. You're going to take that AV bundle. And I think more predictable and planned micro techniques will lead to more success than when you're stuck in a pinch and you can't reach, and then you're scrambling to find a solution in an already, in a vessel that's already thrombosed, and then you need to graft it. And so you're searching for a vein graft, something like that. So I think it's more so than the actual, I think the advantages of having those AV connections and the stability of the soft tissue around the AV bundle can't be ignored. But I also think that it has in part to do with whether you're anticipating needing it or whether you're searching for an AV loop or a vein graft or an AV bundle graft in a dire time when you're trying to solve a problem in the OR. That's my opinion.
Yes, planification is the key, but sometimes in Latin America, we only have like a Doppler and we can use for mark the perforators and that's it. We don't have like maybe HOTC and every, for good planification that is actually reading in the books and reading in the articles how you can do it. But sometimes in North America we don't have that, so we have to like figure it out during the operation room and try to fix the problem that we have in that moment. But thank you so much for this article. I will totally try next case that I have a show length this AV graft. Thank you.
Yeah, I completely agree with Dr. Kareh. A lot of times when we're using vein grafts, it's because it's for flap salvage, and it's so easy to harvest vein graft. We've all done it. We can do it in 10 minutes or less. So then when the flap is ischemic, you're doing a thrombectomy, you can get a vein graft from the foot or the leg very quickly. All of us are comfortable with that. But to harvest an AV bundle graft, like the lateral femoral circumflex artery or even the deep inferior epigastric artery, it does take time because it's much deeper. You got to do an intramuscular dissection sometimes. You have to clip all the side branches. So I think it's a better, more physiologic interposition AV bundle. However, it does take more time to get it. The other thing I wanted to add was I've done a lot of AV loops. And one reason I use AV loops is because I want to test the system or test the recipient site to make sure that it flows, that the recipient vessels are working before I connect our flap. So what I usually do is we'll form our loop and we'll let that go for a few hours in the OR as we're harvesting our flap. And those few hours, we know the recipient vessels are good. They're working. There's an inflow and there's an outflow. So by the time we connect our flap, we know we have a good recipient vessel to connect to. But looking at this paper and really thinking about it, there's no reason we couldn't form an AV fistula between the artery and the vein in these AV bundle grafts and test the system the same way. So that's another thing we can consider to look at.
I see. Minjung, do you have any other question?
No, I'm good.
Dr. Shu, so in the article, you described a different technique. And you talk about the advantages and disadvantages of each technique. And in certain circumstance, one is better than the other. But what if all the situation is same? What do you prefer among the three different techniques?
Yeah,
Two techniques actually. Flap lengthening or what was the pedicle lengthening? Yeah.
Yeah, my preferred way of doing this would be to lengthen the recipient vessel before dividing the flap. So you only have one ischemia time. But that's not always possible. For example, like in the paper, they describe where there's repositioning. So one case example I could think of is if you're doing some type of head and neck reconstruction and you are harvesting a parascapular or a latissimus flap, and what you can do is you can harvest the flap, connect it in situ to the lateral circumflex femoral artery in the thigh, reposition to supine, so you can do a neck dissection on the other side. For example, let's say the ipsilateral side is radiated, there's no vessels, and you go to the other side. It's much easier to do when you're in supine position, get your vessels out, and then transfer the whole flap with the lengthened pedicle at the same time. Another situation would be, I've been thinking about this because we've all run into these difficult cases where there's a large lumbar sacral wound from whether it's a spinal hardware or infection or pseudomeningocele, and we've run out options. They've already had paraspinal flaps. They already had like a SCAP flap, and there's not many good local options. So one option you could do is what we call a latissimus slide. So basically, you're taking the latissimus flap and putting an interposition graft or whether it's a vein graft or AV bundle, and slide the latissimus down and use the latissimus to cover the lumbosacral defect, because normally a latissimus won't reach that far, even if you flip it on its minor pedicle. So one option is to prevent the muscle from being ischemic for too long. You can take the muscle, connect it to the thigh, to the AV bundle, and then reconnect it to the thoracodorsal vessels up in the armpit. So then your ischemia time is only as long as it takes to do anastomosis. So it's much better. So that's one option we could do for these complicated defects.
Thank you. And Rocío, do you have any other question?
No, thank you.
Okay. Thank you everyone for your time and for supporting APS.
Thank you everyone for joining us this fantastic discussion. Be sure to tune in for the other article that we'll be discussing on this month's Hot Off the Press. You can also connect to Global Plastic Surgery Society through our YouTube channel, Facebook, Instagram, and Twitter. We're looking forward to meeting with you on our APS social media. See you soon.